Great. Thank you, everybody. So just a couple of starting pieces of information. One is if you can make sure that you all mute your phones if you are not speaking, it would be really helpful. There's some background noise. Two, if you are able to use your video, it would be terrific, because in these days of social distancing, we're not seeing an awful lot of each other. So it's nice to see, it's nice to actually see people. I know some folks are, can't do that for technological reasons, but if you do and you're willing to, it'd be great to see you. Next, I am putting in the chat some information about some free online mental health service that's being offered 24/7 by United Health, just in the event that anybody is looking for a resource to share with anyone. Really, it's open free to anyone. And I just want to say that we're all experiencing some really challenging times. And so we appreciate you joining today. We know people are going to have to step aside for homeschooling or to take care of emergencies or other issues. So we appreciate, and some people have been unable to join us today. So we appreciate it, as we'd said in our email. And we are hearing some background noise still, so remember to please mute your phones. Unless
*6 to mute.
*6 to mute. I'm not sure where that's coming from, but we'll work through it.
I'm not sure how to do that on my phone.
So just hit *6 on your regular dial pad.
To the person that was just talking, I was able to mute you, so you're on mute now.
Okay, perfect, great. So I did want to just mention that two of the people who would normally be joining us today are sick, and one has been already tested and is waiting for results, and another person is grappling with very similar problems with that are symptoms that are consistent with COVID-D, so this is definitely hitting home. But we did not want to cancel this session specifically because older people who are living alone with dementia and or their caregivers are really challenged in these times, and so it made more sense to move forward and to talk about these issues and to share.
You are muted.
Great. Just as a reminder, everybody should be muted, and there are folks who are not that I can see, so please just take a second to check to make sure that you are muted. So without any further ado, I am going to turn things over to Cinda Donton for our didactic.
Okay, so today's didactic is strategies for working with people who have a dementia, how to build strong boundaries in relationships. I usually do at least a 2-hour training on this, so I tried to condense it. Who knows, we may even get done early. Okay, next slide. The relationship you have with the person you provide care to is the most important aspect of the care. And so, in my opinion, relationships are sacred. So everything else pales besides that in terms of the caregiving. Like, the most important part of caregiving is the relationship with the people with dementia remain fairly emotionally intact, and so the quality of the attention we give them can do a lot of good and sustain them as they cope with the tremendous adjustment of experiencing themselves with a dementing illness. Having good boundaries enables us to care for the person in ways that feel caring to both the caregiver and the recipient. The quality of our caring and the quality of our presence matters. Not only will it help us to have fewer regrets when our caregiving comes to an end, but it will also enhance our pleasure in the caregiving situation. Our pleasure in the presence of another human being is not dependent upon how they act or feel or what they are going through. Then we can always be at our best for them and ourselves. And I think one of the goals for me as a caregiver is to try to remain present and caring in spite of what is going on. Next slide. The essence of boundaries is knowing what is your responsibility and what is not your responsibility. So This is my definition of that. You're responsible for how you think, feel, and act. You are not responsible for how someone else thinks, feels, and acts. So basically what I teach people is to learn how to mind their business, which is how you think, feel, and act in the face of how other people are acting, thinking, and feeling. And that will benefit you not only in caregiving, but in any situation. People will feel safe and not judged when we learn to mind our business. And for people to feel accepted and to feel free to be authentic really helps them to focus on what their job, which is to be responsible for how they think, feel, and act. We will feel less stressed and be able to stay in a place of caring and acceptance and have no reason to burn out or develop compassion fatigue if we're able to figure out how to do this. It is really hard to empty yourself when you have good boundaries. Next slide, please. Caregivers often have trouble with this. They believe that as part of their caregiving, it is their job to help the other person feel happy, think in ways that they deem reasonable, and do what they think the care recipient should do. In other words, what the caregiver feels is in the best interest of the person they're caring for is what they're trying to help the care recipient do. So we're kind of raised this way. You know, we're raised to think that it is really important that we make other people happy and that we try not to hurt other people's feelings. And we're sort of raised to help people think well of us and to think well of other people. And when we're doing that, it's very difficult to do our job, which is to be responsible how we think and feel. And I don't think we realize how often our belief that it is that we are responsible for other people causes us to alter the way we act when we're around them. We try to influence how they feel, what they think, and what they do. So cultivating humility will help with this. And I'd have to say one of the most important enlightenments I have experienced as a human is the realization that I have no idea what other people should do. This humility, this realization creates a space where I can feel caring while I observe what other people do, knowing that what they're doing is none of my business. My business is how I respond to what they do. And this is sort of a radical shift in thinking. So one day I was driving down the road and I noticed that a man pulled out in front of me and it was slippery and it kind of scared me. And I remember thinking he shouldn't have done that. And then I had this amazing thought, like, how do I know what he should do? This is ridiculous. How arrogant is it to think that I know what somebody else should do? And I started laughing. And that realization that I had probably 15 years ago has really changed me as a caregiver. It has really helped me to be humble and recognize that in any situation, I have no idea what the person should be doing, whether they have dementia or not. Next slide, please. Recognize that you cannot make someone feel, think, or act in any particular way. It is virtually impossible. We don't have control over how other people think, feel, or act. And as it is not possible, investing ourselves in trying to make somebody think in a particular way or feel a particular way or do something in particular is a waste of time. And it often alienates the care recipient. When I was working with people who had chronic and persistent and severe mental illness, I worked with a lot of younger men who were basically considered to be non-compliant with their medications. And in my work with them, I never tried to persuade them to take their medication. What I did is I told them their rights, that they didn't have to take their medication, that only a judge could make them take their medication, and what would happen, and that didn't, and that was a rare event for a judge to order that. And what would happen if they did or they didn't. I just informed them, and then I gave them the space to make the decision that they thought was in their own best interest. And what was really interesting about that was that I noticed that all my clients took their medication. They had decided on their own that it was in their best interest to do that. That was very interesting to me, that I wasn't trying to get them to take their medication. I was simply informing them of what their rights were and giving them the space to make that decision. And yet that was the decision that they made. And that was not true of other case managers who tried to get their clients to take their medication. And so I did some research on this, and I found out that people are naturally rebellious. And so when we have an agenda for them, they often go the other way. And that has really informed my work. So being a humble caregiver means realizing that you don't know what is in the care recipient's best interest. And the truth is that we want people to do what we want them to do a lot of the time. You know, we have ideas about what we think, how we think other people should behave, what is in their best interest, how they can make themselves happy, and we are really invested in that. Especially when we believe that an individual may no longer be capable of making good decisions. So it may seem necessary to get the care recipient on board with doing what we think is best for them. But this comes at a cost. And the cost is to the relationship we have with the individual. And the cost is also stress for both of us in our care recipient's experience and in our own experience. And this is a result of not having good boundaries. Okay, next slide, please. The realization that we do not know what others should think and do has important consequences on the choices we make as a caregiver. And I just gave an example of that, recognizing that it was not my job to have to make my clients take their medication. It was not my job to even try and persuade them, really freed me to have a relationship that allowed them to fully trust me and to feel safe in my presence. And that somehow created a space where they were also able to feel safe doing what they actually thought was better for them. They were not trying to rebel. That was off the table. They were trying to think about what was best for them. So we're able to go from trying to get them to do what we want to honoring their own path through living with dementia. So for instance, let's say that as a caregiver, we want the person that we're caring for to eat 3 meals a day instead of only drinking chocolate milk.
March 26, 2020.
Wanting them to take their medicine when they need
It's 3/26/20. Nice.
We may want them to attend medical appointments when they refuse to do so. We may want them to sleep at night when they prefer to sleep during the day. And so, and I recognize that that's hard on care recipients. Caregivers, I mean, when they see people acting in ways that are hard on them, like when they want to sleep at night and the person they're caring for is not, that can be very hard for them. But the truth is there's no real point in investing yourself in trying to get something to happen when you can't make it happen. That just leads to more stress and erodes the relationship. So I'm trying to present ways that are more skillful than trying to force an outcome that you don't really have the power to enforce. Next slide, please. So my suggestion is you invest in your relationship with the care recipient and not in a specific outcome to the caregiving. If you care more about your agenda for the care recipient than your relationship with them, you will have difficulty trying to achieve your agenda, and the caregiving will feel more onerous. And the care recipient will know that. They remain pretty emotionally intact. They will be aware of that. People know when we want them to do something. They know they are able to read us more than we recognize. And we're able to read other people more than they recognize. It is more skillful to be respectful of the choices of the care recipient, pay close attention to what they are choosing for themselves, and let that inform how you provide care. For instance, if you notice that the person you're caring for doesn't like to eat regular meals, but likes to drink chocolate milk, then you may think of ways to make that chocolate milk more nutritious by using chocolate Boost or Ensure or Carnation Instant Breakfast, or adding things to it and seeing if that's acceptable to them. So you're kind of going with their choice and trying to make it work for them. People do not like being controlled, and they will often rebel against an agenda. They want to be respected and to have some level of self-determination. This is true of all people, whether they have a dementia or not. Next slide, please. Trust people. They always have good reasons for what they are doing. That's hard for us, you know, to trust people at times when it seems like they're doing something that's not in their best interest. But if you're humble and you realize you don't know what is in their best interest because you don't know how somebody else is supposed to act, you only know how you're going to act, then it really benefits the relationship and is less stressful for you. For instance, I was asked to visit a person who had a dementia. He was living in a residential care facility and he wasn't eating. And the man had known me because I had treated him years ago and helped him get sober. So I went out to visit him and he remembered me very well, and he was so happy to see me that he was eating while he was talking to me. But I asked him that, I told him that I heard that he was finding it difficult to eat. And I told him, I know you have a really good reason for doing that, and I'm just wondering if you would share that with me. And he told me that his mouth was incredibly sore. So we got the doctor to come out and look at him, and he has some sort of like a bacterial infection or something in his mouth, and he was treated for that, and then he was able to eat. So people have good reasons for what they're doing. Like if you have schizophrenia and you believe that somebody's beaming rays into your head from a spaceship and that it's going to control you if that happens, and you think a tinfoil hat is the only thing that's going to stop those rays from being beamed into your head, you're going to wear the tinfoil hat. So you have a very good reason for wearing it. It's just not always possible for people to share their reasons for doing something, but people have reasons for what they're doing, no matter what it is. For instance, if they're not taking their medications, they have a reason. Rather than try and force the issue, try offering different mediums for the medication to be in: liquid meds, dissolvable tablets, crushed medication, and applesauce, etc. That may not work, but you can try, and if it doesn't work, it doesn't work. But you can try. You can use what you're noticing about what the person's doing or not doing to try and help inform you how to provide better care. Using people's choices to inform how to provide care is more respectful and therefore more effective. And it is also a better way to keep the relationship intact. Next slide, please. I have found that my respectful, humble, and trusting approach has made it easier for folks I work with to make choices that reflect their personal goals. Not my goals, but their goals. I tell my clients that they are the experts on themselves, and I trust them to choose what is right for them. Also, and you know, doing that also sort of reduces the burden of feeling responsible for the decisions that somebody else makes. Because we do, you know, people that we're caring for, we feel like we're responsible for the decisions they make, and recognizing that we're not, that we are only responsible for coping with how we feel about what they are doing, choosing to do or choosing not to do, is so much easier because that's doable. Making people do what we want is not doable. Next slide, please. There are times when limits do need to be set with care recipients. For instance, I would try to stop someone with advanced dementia from using a chainsaw, driving the car, or operating a cook stove. But I would do it in a way that was as respectful as possible. I remember one time I had a client who was suffering from a delirium, and it took us a while to figure out what was causing that. In the meantime, I recognized that he was not safe using his cook stove, and I called the landlord of the congregate housing site where he lived, and I asked them to unplug it. Before they did so, I told him that I had called them, I was having them unplug it, and I told him exactly why. I explained about the fact that I thought he had a delirium, and that, you know, we were still trying to figure out what was causing that. And as soon as he was restored to his former cognitive functioning, we would plug it back in. He wasn't happy with me, but because I was so upfront about it, it did not harm the relationship. So we want to handle this as respectfully as possible, but safety is paramount. And it wasn't just his safety, it was the safety of others. However, when weighing setting limits, the needs of the relationship must be considered, and that's why I did it the way I did it. I didn't want him to have I knew he would blame whoever unplugged the stove, and they were just doing what I recommended. And so I made sure that he knew that it was me that had done that. Next slide, please. Not having an agenda for the care recipient, but focusing instead on caring about them and the relationship you have with them leaves you with the possibility that you will be less stressed, frustrated, run down, and angry. With good boundaries, we are free to work on coping healthfully with how we feel about what the care recipient is experiencing and doing. For instance, if my husband with dementia is not wanting to go for walks or exercise, I may notice that I'm afraid that his exercise avoidance is going to mean that down the road, he may not be able to remain at home. Recognizing my fear allows me to work on coping skillfully with my feelings rather than trying to coerce him into exercising. I have seen what has happened when caregivers do try to coerce. I remember speaking at a workshop that I provided to caregivers down in the Bennington area one time, and there was an elderly woman there whose husband was about 90, and he had an Alzheimer's type dementia, and she was very, very intent that he exercise 4 times a week, and he absolutely hated it, and it wrecked their relationship. And so he did not enjoy his life, and he no longer enjoyed his wife because of her agenda for him. And I mean that's a caregiver's choice if they choose to make it. But personally, I care significantly about the quality of life of the care recipient, and I also care about the relationship that I have with the people that I provide care for. Recognizing that we are not bound by the choices that other people make is really helpful, because I think that's one reason why we do have agendas for other people. We think that if a person makes the decision not to exercise, then that's going to bind us somewhere down the road. We're going to be, our choices are going to be limited, but we always have choices. You know, you can choose to get help in the home. You could choose to have the person admitted to a facility if they can no longer transfer, or there are other even more radical choices you could make if you wanted to. But we always have choices, and when you recognize that you are not hampered by the decisions that other people make, your care recipient makes, when you recognize that you do indeed have choices, then you can feel free to allow them their freedom of choice. For instance, I was counseling a caregiver whose husband had a frontal lobe dementia, and he was doing some things that were very, very upsetting to her, and she was finding it hard to be around him at all. She just didn't want to be there. And she told me she was thinking of leaving him. And I said to her, you know, you should feel free to try and think through what is best for you. And so that you know that you can make the decisions that are in your best interest, regardless of the decisions that he is making. And so I basically gave her permission to do what she wanted to do, whether that was to leave him or not. And that, for some reason, that really helped her a lot, having my acceptance that I would be okay with her leaving him if that's what she chose. She didn't. In fact, she stayed with him another 2 years until he just literally couldn't transfer anymore, and was very recently admitted to a nursing facility. But he, you know, it's okay for people to do what is in their own best interest, it's okay for caregivers to do what is in their own best interest. What I don't think is okay is to try and force care recipients to do what we want them to do. Next slide, please. It is worthwhile to work on being okay with what the care recipient is going through as the dementia progresses. Often it is hard for us to watch other people because we may think they're suffering. We recognize we wouldn't want to go through that, and we don't know how to not. A lot of times we don't know how to not suffer when somebody else is. But the truth is when someone else is suffering, it's not your turn. And if you're not suffering when they're suffering, you're better able to help them, because you're not so focused on how you feel about what they're going through. You're more able to be supportive of what they're going through. So I think it's really important to recognize when you're struggling with what you're watching or what you're observing that the other person is going through, and have good enough boundaries where you recognize that because somebody else is feeling this way doesn't mean you have to feel this way. I have really noticed that it seems to me sometimes that caregivers are more unhappy about what the person's going through than they appear to be. And so if we can work on being more accepting of what is, because you can't change what is, you can't change reality, you can only change your response to reality. So if we are more accepting of what other people's experience is, what they're going through, it can help them to be more accepting too. I have noticed that when I tell someone that I think that they may have a dementing illness and that they should get further testing, they handle it very well because it doesn't upset me to tell them that. And that has been, when I've talked about this at conferences that I've spoken at, it's been kind of shocking for people. You tell people that you think they may have some sort of a dementia, and I say, yeah, why wouldn't I? I really believe people can handle what I have to say to them, and I think the fact that I can handle it makes it easier for them to handle it. They realize it's not something, you know, totally dreadful or to be ashamed of or to feel sorry for them about, because I really think that people can handle what their lives bring them. And I do think that's helpful to them, and I know that it's helpful for me. So if we feel sorry for them, it could impact how they feel about themselves or about what they're going through. And we want to equip people to be as effective at coping with their experience of dementia as they can. And I think we can help people to not feel as diminished by it by being okay with what is going on and by continuing to respect their ability to cope. I really believe that acceptance is a very powerful choice. Next slide, please.
My mother passed away in December, by the way. Look, you have to call me back.
Learning how to respond healthfully to how you feel about your caregiving experience is important. We often feel like we are not doing enough, that we are failing the care recipient in some way, or we may notice that we do not like who we have become in the caregiving situation. Because we get frustrated, we get stressed, and sometimes that's apparent. Acceptance and self-compassion is a skillful response to the stress of caregiving. You can tell yourself, it is okay to feel this way, and I'm doing the best I can. We need our own kindness and encouragement as we navigate through the caregiving experience. And one way to do that is purposefully to say things to yourself that is encouraging. Like, I will always know what to do. I'm doing the best I can. My care recipient is okay in this moment. I do not need to go into the future. I can handle what each moment presents. Next slide, please. Finally, find ways to enjoy the person you're caring for. This is easier if you stay out of the future. Focus on what you like about them and the time you spend together. Really pay attention to what you like in the situation. I notice that when I do that, I enjoy everything more. When I focus on what I don't like about it, I don't have as good an experience of whatever it is that's going on. I always try and focus on what I like about what's going on. And then I magnify it for myself by commenting on it. Recognize that this time too is special and meaningful. Thank you. That's all I have to say about it.
Thank you, Cinda. That was great.
You're welcome.
Jess, you're muted right now. Does anyone have any questions for Cinda at this moment?
You're funny. That was what I was going to say. I was going to say we've actually got a couple of minutes. Good job, Cinda. So if anyone's got any questions or comments, that would be this would be a good time.
And all of you are muted, so you may, if you're on a phone, press *6 to unmute if you do.
Okay, well, hearing nothing, I think we're going to move forward then, and thank you again for that presentation. And so we're just going to take about 5 minutes now to open it up to questions that folks may have in terms of and or share resources. And so we're going to actually completely not follow the echo session rules right now, and let folks ask questions about COVID-19 and how it's impacting folks with dementia and their caregivers, and anything that you have heard or seen that is being successful at engaging with these issues. And I will note that, for instance, and unfortunately, Catlin Blackstone of Southern Maine Agency on Aging couldn't be with us, but they had to close their adult day program because of concerns of spread of COVID-19. And so while they've had to lay off a lot of their staff that were part of that adult day center, they were able to retain their social worker and are having their social worker call both the families and the people with dementia every day to check in and see how things are going, and to connect them with resources in the community. So that's just sort of one idea of good things that are happening for challenging situations. So I'm just going to stop talking now and ask others to ask questions or share information.
And just remember, you guys are all muted right now, so you'd have to unmute to speak, and we want to hear your opinions and suggestions and ideas.
Hey Jess, Tamara Herrick here. So as part of the grant, we're doing the resources for enhancing Alzheimer's caregiver health with Maine Behavioral Health and Maine Medical Center's geriatric social workers. And so we have transitioned all of those, which were formerly in-person sessions, to telephonic. And so far it's working well. The caregivers really appreciate that we are continuing that.
That's terrific.
Hi, this is Joanne from the Wilmington Group. And Mark, I'm going to ask a question, and to everybody out there. You know, now that people are not supposed to do a lot of face-to-face caregiving and so forth, how do we handle the caregiver respite grants that we give out? In other words, if the caregiver is really getting burned out, we can't really send another person into the home at this point, can we?
That's true, and it's certainly a hardship. And also, I've had calls from people who are being paid to provide respite, who are now basically out of work. So this is certainly a tremendous hardship on both the care givers who depend on that respite, and some of the respite people who were depending on a little bit of income. So there's no good answer for that. There's just no good answer for that because people need to shelter in place and not allow lots of other people into their residences. So it is kind of a dire situation now all around.
So home care workers, though, have been deemed essential, and so can, in fact, continue to go into the home. And most home care agencies, at least in Maine, and I know we're living under a little bit of a different universe across the 3 states. We don't actually have a formal, except for a couple of cities, a shelter-in-place order. But at least in Maine, home care agencies are taking sort of all reasonable precautions and are still serving people in the home.
Yes, that's true. I've been having active conversations with the local VNA, and they are certainly triaging their personal care services, but they're very active in wanting to convey the message that yes, they will continue to provide the services, really the essential services as necessary with all the due precautions.
This is Sharon from Aroostook, and so one of the things that we've been doing, because we do have an elder care program here, so we're continuing to provide care in the homes. A few snafus, some consumers do not want to have workers coming in, and some workers are not willing to go in. So we've had to contend with that. One of the biggest essential pieces is developing a very strong, viable contingency plan. And so all of the people that have been identified on the contingency plan are being contacted to make sure that they're going to be able to go in. It's not just the personal care that we're worried about, but it's being able to obtain their medications and being able to obtain groceries. The RSVP program is working diligently to find volunteers that are going to be willing to pick up groceries, pick up medicines. I think one of the most fantastic things, there's always a silver lining, isn't there, is looking at seeing what some communities are able to do. And they've really pulled together, depending on which community you're talking about. We've seen restaurants who never had drive-through service. They've developed the ability to drive through to get food. We have grocery stores that have opened up their hours for older people so that they will have limited contact with others. We've had grocery stores that are willing to deliver food. And so we've been able to put together some of those lists to be able to help the community out.
Thank you. And talking about emergency planning, I'm curious if anyone has any good documents that actually help caregivers and or people with dementia sort of do some personal emergency planning. I'm speaking with folks who do resident service coordination and project managers, rural housing development project managers tomorrow, really helping people think particularly about this population that may not be able to successfully shelter in place, particularly if a home care worker who has been usually caring for that person can no longer go provide that care for whatever reason. So I'm just curious if anybody's used any tools.
Yes, this is Leslie Furno. I can't respond directly to that, but I do have a nagging concern, which it comes from the experience that I've had in the past about healthcare, the healthcare system in general, that doesn't value the diagnosis of dementia as an emergency or a real thing. And what I'm thinking about, for example, the previous conversation about having nurses, home health nurses going in to care for people in their homes, or nurses or aides going in. And also, I think it would impact on that emergency planning is that in the past, I've had the experience of medical professionals, when somebody goes into the emergency room with dementia, saying to family members, well, you know, he or she doesn't really have anything wrong, they just have dementia. And that dismissal of the disease as something that is important might lead to not sending, if you're having to triage your caregivers, the care providers, the professional care providers, about who is going to go into someone's home, for example, and which homes to go to. The hospices, for example, would prioritize people who are having chest pain or shortness of breath or some other disease, but might not have the same priority for families that are dealing with dementia. So I just throw that out to the group.
Thanks for that, and I appreciate it. So we're gonna have to move on to the case presentation at this point, but I do want to say, if others have ideas or tools that they're using or resources, please share them in the chat. We copy the chat and we'll include them in the notes that we send out to everybody. So thank you so much. And now we're gonna turn to our friends in Vermont. And I think Jennifer Fitzgerald, you're gonna be the case presenter this morning.
Yep, I'm just trying. Oh, am I on now?
You are. We hear you.
Okay. So my case involves a 75-year-old female whose longtime friend came to visit her about a year ago and discovered that a previous history of hoarding had escalated. And so she wanted to help her get her needs met. She had no running water, no heat, no electricity. And this was in late February, early March last year. So she set to work on how to do that. And that is what raised my primary questions. Should that be done now or after I tell all the history?
I think, why don't you go ahead and tell the history and then ask the questions.
Okay. So as the client's denial increased regarding her dementia and hoarding, it was affecting her health, her ability to face mounting debts from unpaid bills mostly, and contributed to her isolation and withdrawal from reality. Her known history of alcohol misuse and forgetting to take her meds was also a problem. So Carlotta, who is participating today, will answer a lot of the questions that may come up. Had a really difficult time even finding words for what she saw at that home. It was more than just collecting a lot of papers or clothes or unopened mail, but it was also uneaten food or moldy food, or because the refrigerator wasn't functioning and the stove wasn't working. The odor was terrific. And then after all of that, she discovered 2 cats in the home that had been littering indoors. And the patient would feed the cats before she'd remember to feed herself. So the patient had limited transportation because she had voluntarily given up driving the previous year. But she would often call friends to take her shopping or for doctor's appointments. But sometimes, she gave the wrong date or she wasn't ready when they came. So Carlotta was able to keep her organized with that and would stay with her on all the appointments to share, what she was seeing in her friend. As for family history, the client was born in France when her parents left Poland during World War II. And it is known that there was a family history of mental illness as well as dementia. The client's family later moved to the United States, settling in Queens, New York, when the client was 11. The client moved to the Deerfield Valley in the early 80s and purchased a property that included a retail building and an adjacent house with 4 attached apartments, which would help her obtain rental income so that she could open a ski shop in 1985. In the 90s, the client researched adopting a child, and in 1999 actually went to Russia to adopt an 8-year-old girl who essentially presented with severe mental and developmental challenges. And yet the client brought her home to the United States to provide care and try and integrate her into the community. But that relationship often had volatile occasions of verbal and physical abuse in spite of, their best intentions. And the client's friends were always supportive to her as well as the adopted daughter. So the client, the issues that have been resolved so far is that with Carlotta's help, the client, she was able to organize the services that the client was receiving. And there was one agency that was considering filing for emergency guardianship, but Carlotta decided she wanted to become her guardian. And after being appointed temporarily, she was able to secure supervised housing with the help of various agencies, and the client could then transition to an assisted living facility, which is where she is today. The client's home and business in Vermont have been sold to pay off her debts first, and then the remaining assets have been put into a trust for the client to remain in this assisted living. It was accomplished primarily because of Carlotta's really pushy way of getting the resources and the help that she needed to find her friend a safe, healthy place to be. I feel this is an opportunity for us to understand some of the stressors raised by this individual case, and to thank not only Carlotta, but my colleagues in the service providers that helped make this a reality. So the primary questions no, I have a little more information, I'm sorry. There were incidents involving first responders, which primarily were to intervene in altercations with tenants over non-payment of rent, the tenants doing work for the client that she'd bartered for, but then overlooked or forgot what they'd done. Incidents with fire or alarms going off in the client's home, or primarily the rental properties, and situations involving verbal or physical abuse within the family or the tenants or contractors that had not been paid. And the current service providers were the Deerfield Valley Health Center, where she had a primary care physician, Senior Solutions, who offered multiple programs that Carlotta was able to tap into and that the client was already receiving, including Meals on Wheels and I think transportation to the meal site. She also had church support, services from HCRS, which is the mental health provider for our area, not only, well, primarily for the daughter. And Twice Blessed is a thrift store that donates, holds the money to pay for people's fuel assistance at least one time if there's an emergency, and after making sure that they're connected to the service providers in the state that, you know, may offer that as she might qualify for. And the Mover is our local transportation provider that has scheduled routes in the valley, but also has contracted ability to pick people up to bring them to the meal site or the gathering place, which opened an adult day program in Wilmington. Families First, who were providers of people under 23 that had multiple disabilities or developmental needs. And then finally, Brookdale at Fillmore Pond is the residence that took her in lieu of the potential sale of the building. And even after a crisis situation, after they had to lock down the building because of illness, Carlotta looked at an inpatient dementia unit that would take her, but they were waiting for a single room because the patient really has difficulty not having her own space. And it's all been resolved now that the crisis is over and she can stay where she is. So the questions that I came up with in this process were, how can agencies coordinate services if a client has not given permission for them to collaborate? That was a barrier at first because nobody knew Carlotta, and they and the client herself wasn't willing to let her express her views of what was going on. How can non-medical or professional caregivers glean information that might help them better meet the client's needs? So often, if Carlotta wasn't with her at an appointment, information that might impact their treatment options was finally elicited. Are there opportunities for an intervention if relatives, friends, community members, or agencies report self-neglect concerns? And what I mean is several different groups of people did report self-neglect, but I'm not remembering the phrase that's used for patient self-determination, but if she was refusing services, she was respected and not offered the help that other people might think she needs. So is the lengthy process of applying for temporary or state guardianship the only option left for people that have concerns and don't have the skills that our didactic presentation gave us today?
Yes, that's Cinda's definitely, it's a practice that we have to.
I'd love to see that.
We're all aspiring to, right?
Absolutely, absolutely.
Anyway. Well, thank you, Jennifer, for that. And certainly this case brings up, and it's thankful that it's resolved, and that Carlotta, who is with us today, was able to be such an incredible and effective advocate in this situation. Unfortunately, for far too many people, they don't have that sort of advocate. And so I think particularly as we're thinking through recommendations at the end of this conversation, offering those a little bit more globally for people who are living alone and or who don't have family members who have that sort of advocacy capability, sort of the kinds of supports we can put in place in those situations, and certainly complicated by the idea that she had a rental property with renters still in the property. So I'm going to open it up now, as we do, for clarifying questions. So just clarifying questions, and just from our spokes cohort, so from our communities. So who has a clarifying question that they would like to ask?
And remember, most of you are muted, so you'll press *6 to unmute, or unmute the button on your mic on the computer.
I have a question.
Okay, we can.
I'm wondering how the person handled Carlotta coming in, that the woman or the man left their home, and all the steps thereafter. What kind of resistance was there, and how did Carlotta handle that? Because that's always so challenging.
Can you hear me?
We can.
Okay, this is Carlotta. Yes, at first, my friend was in denial that she needed help, that her house smelled so bad. I needed an N95 mask to go in there, and the place was clean. So I had to firstly get over that hurdle, and that was the main thrust of the need for her to get out of these deplorable living conditions, between not having electricity, plumbing, heat, water, flushing toilets, and the cats, the smell, and to try to, my first goal was to remove the cats, because there was cat food, dried up cat food all over various dishes, piled mountains high on top of the stove or whatever. So that was my first goal, and to try to have her be in a different room, or I tried to have a mutual friend and or her realtor take her out for lunch while I kind of got through, and I ended up throwing out about I think it was 68 giant green garbage bags, and it hardly looked like it was a dent made, almost to the fact of when you watch, if you ever do those hoarding shows. So I had to try to gain her trust through all of this, and it took a lot of effort. I took her to my house so that she could take a shower, and which she refused to do and still does. And when she kept coming back to her house, I was hoping that at some point it would sink in that this was unhealthy situation, and it did finally, but it took a while. But her resistance and denial of needing help from anybody was the big hurdle. She gained my trust, and that's how we were able to move forward and also when I took her to the doctors, I took her to a memory clinic that she had been to before for a maybe 4th evaluation, and they, acknowledged to her that she had Alzheimer's, and just trying to repeat many times the situation, which she couldn't remember, but the visuals are, sometimes are the way people interpret and can understand and can communicate. So I kept trying to point out to her the various things in her house that we needed to get. That's why we needed to get her out of there and get some help.
Other clarifying questions?
Was Adult Protective Services called at any time?
Yes, every month the agency got the report, and the notification would come back every month, the same thing, that they didn't see that this was a dire need of stepping in. And I don't know what, and Jennifer we were trying to think, and I don't have my files. I'm actually in New York City, hunkered down here. So I don't have my files, but I can't remember what the term was, but there's a term that it's almost, you can live in a pup tent if you want to, and nobody can force you to leave. And that was the barrier that all the agencies had, that if that's the way she chose to live, we couldn't force her to leave. The one thing we were able to do is that the town was able to condemn the rental property, because the tenants had no, services, utilities either. So that you can condemn, but because I went to the town and no, they couldn't condemn private property. They can condemn retail property and also rental property, but not personal property.
Other questions from our spokes?
Oh yeah, Carlotta, do you still have contact with her?
Yes, I just spoke with her yesterday. She luckily, as we presented, that she was able to sell her property, and which she still doesn't kind of remember that. She still asks about it a lot. She sort of knows that it's sold, but what happened to her things inside the house, and what happened to her belongings, and which before she moved, I did remove some personal things for her to hang on the walls, and so some pictures and all that. So she has relented to the fact that this is her new home, the assisted living place, but it still hasn't sunk in that her other home her real home shop has been sold. She admitted yesterday that she's actually happy there, but that comes and goes given her up and down stages of her awareness of things.
Right. Thank you.
Yeah.
So now I'm going to move to clarifying questions from faculty. And certainly if there's others from spokes, feel free, but I'll open it up to our faculty now.
Was it an emergent? Was the temporary guardianship, was that a voluntary? Did she agree to it, or was it involuntary?
It was involuntary.
Thank you.
Can you give a sense of the time period that this all happened over, from the time that Carlotta, you decided that she should not be living there to when she went to assisted living?
She had been a hoarder for maybe 7 years, and it just got out of control. I'd say in maybe February, March, and of course then when she had no heat, and she had burst pipes, water pipes, and plumbing issues that had been somewhat, the emergency repairs were made. Of course, the bills never were paid, but that had started in the late winter, and then in the spring is when I think it was maybe April, I stepped in and said, we've got to get you some help, services. She had filled out forms through the different agencies, but they never were sent in, or she didn't sign them, and then she refused to sign them. So she hadn't gotten, of course, there was no fuel assistance to get, but food stamps or any kind of extra help. I ended up driving her myself to the Medicaid office and to fill out the forms once she gained my trust and I said that she needed this help. So that was in the early summer. I met with the guardianship person from Montpelier who drove down and interviewed me, helped me fill out the forms. I believe it was in July. She also met with my friend in her hoarding situation, interviewed her, and then I think it was in September or August, I guess it was August. I'm looking at the guardianship papers here. August was the actual filing of the involuntary guardianship. I was also told through the guardianship individual that there's a very long list of guardianship needs through the state, and not enough people who can act as state guardians, and that there are a lot of very big emergency type of needs. So that's when I knew my friend would not listen to a state guardian, and that she would, because there were very other complicated issues. But so I stepped in. So it was August that I had control, sort of like, I want to say, ability to step in, because if you can't do a lot without having that paper, that guardianship paper or power of attorney, because of HIPAA, laws, and if you're starting to suggest that somebody needs to go into a nursing home or whatever facility, somebody has to sign off on that, and you have to have a guardianship. So that was an important piece.
Thank you. We have a couple of minutes for one more question, one more clarifying question.
This is Laura Davey in New Hampshire. I was wondering if there were any, her primary care, and I'm sorry if I missed it earlier, were any medical folks on the medical side of the house involved in her care, or did she talk with any of them?
Yes, yeah, that had been ongoing, and I was given permission by my friend to go to those medical primary care meetings. And the social worker was also involved. I spoke with her, and she's the one that actually tried to explain to her that she had Alzheimer's again. Yes, and they had to provide documentation for the guardianship. It was quite involved. The state had to do a state evaluation through the nurse who came to interview her and me, and I have like a 10-page document of the evaluation that we came to the conclusion that yes, she needed to have a guardian.
Thank you for those clarifying questions. And now we will move to recommendations. As we do, we'll start again with the folks in the community, the spokes community. And just as a reminder, in a global sense, the questions are: what are the best opportunities for an intervention when there are reports of self-neglect concerns, and how can community resources best collaborate when there isn't specific consent for information being shared? And then finally, are there other less timely and challenging alternatives, as Carlotta just described, to guardianship that we could be considering in cases like this? Go ahead with recommendations from our spokes.
Again, this is, we had a situation similar to this in the North Conway area, and something that happened in the small town that this particular person was living in. The town fathers and the town manager was able to go into the home and declare that it wasn't safe for the town to go into if there was an emergency, like fire or ambulance. So that was an angle that they were able to take that seemed like it could have been helpful here.
Terrific. I know that we've used that similarly in Maine. Additional recommendations?
Yeah, I think another recommendation would be, and I know this was probably an effort was made, but I think getting the medical people who knew her willing to confirm that she didn't have capacity, because it sounds like you tried to get Adult Protective Services and they somehow believed she had capacity, but she clearly didn't have capacity. And so that's an ongoing problem in different states, and different adult protective organizations have a different level of tolerance on that. But really, I think doing that early on is really key, so that then you can get the guardianship going more quickly.
I could be mistaken, but I don't think that Adult Protective Services has the legal capacity to declare somebody incompetent. Don't the courts have to do that?
Yeah, but yes, the answer to that is that's correct, but they kept dismissing it because they said she had capacity to make decisions. And so they kept, I mean, it's a vicious cycle, right? I mean, they're dismissing the effort to try to get help in there because they say, oh, she's allowed to make her own decisions. And so that judgment of capacity early on, I think, is really helpful, or incapacity. And that requires medical professionals. That requires somebody, in the medical world making that.
Right, they have to bring the evidence before the judge that the person is incompetent. So that has to be done very early on, or basically all the state organizations are pretty helpless.
They always threw out the fact that unless there was self-harm, and I guess you have to determine what the back meaning of those words are, that they couldn't be could be forced out.
Having a physician make a house call would solve that.
Mm-hmm.
So that's going to be a recommendation, yes, Leslie, having a physician make a house call.
Yes.
Other recommendations from our spokes communities? I did not mean to hit that button. Okay, I'll assume your silence means there's no more recommendations. So we'll move to our faculty. Mary Val?
Well, I have to say, Carlotta, that I felt for you in this situation because I too have had other friends and neighbors report kind of a similar thing. And a lot of times the anguish that they had was so palpable. You know, it was, they were reaching out, trying to help and not getting anywhere. So I felt a lot of times my role was to, you know, help the friend or neighbor understand at this stage in Alzheimer's disease, judgment is usually gone, and, you know, getting the person angry or agitated probably isn't going to be helpful. So I'm hoping that you had someone that was kind of coaching you and also telling you to take care of yourself because, you know, as I said, in the situations I was dealing with, the anguish was palpable. And unfortunately, my advice at that time would not work today in the COVID environment. But one of my, the situation was that person would wander a lot outside, and I said, you know, I think you have to call 911 and, you know, have the police take them to the emergency room, and then a refusal to go home is going to, you know, precipitate some other placement arrangements. But in our situation now, you know, I certainly wouldn't make that recommendation. So it's very hard to think, did you ever get to the point where you thought, you know, I'm just going to have to wait till there's a crisis and then she will be placed?
Well, she was brought to the hospital. It wasn't me, but one of the service agencies, because she didn't have heat. She was evaluated at a hospital, and they released her the next
to home.
Back to home. Knowing the situation, they released her back to home. And I think that she was given some emergency gallons of propane, but still they released her from home. She also did wander away from the adult daycare center a couple of times to pick up her mail, which was in the same parking lot, the post office, and she hitched a ride back to her house. She got, which was just pretty much down the street. We called the police. They went, visited her, and they said she's okay, no problems. She can stay at her home, which is where she was living at the time. So, and lots of people, I heard that, you know, their hands are tied. We can't force her to stay in the adult daycare. They finally realized that it was important that she did. But, and she has tried to wander off from the assisted living place also when she first got there. And she's very, very angry with me, wouldn't talk to me. I was the enemy, and was screaming and yelling and my name.
Yeah.
I'll just, excuse me, remind folks that right now is just a time to offer back feedback and recommendations. So we're going to move beyond the back and forth if we can, just to make sure we hear everybody's recommendations. So no offense, this happens all the time, but that's just to make sure we get the best information out to folks. So other recommendations?
This is Ellen. I would recommend, I would recommend that everybody has a Carlotta in their lives. My goodness, this Carlotta, you did a yeoman's work to make this happen, and your persistence and tenacity is just inspiring. I wish that every patient that I have cared for had someone like you in their life, whether that be a family friend or a family member. So hats off to you for not giving up and for really kind of going at this step by step. That I think the recommendation that I have is that somebody follow your lead and really take this kind of a situation step by step, building trust, working in increments, contacting and connecting with services that are available. Just keep pushing the message that this lady really isn't safe in her home and is living in an unsafe situation, and with her incapacity was really needed to be in a safer environment. But congratulations and hats off to you for a wonderful job. And I just, boy, so I'm saluting despite the fact that you can't see me.
Thank you.
We can imagine it. We can imagine it. Thank you. Thank you, Ellen. And I'm sure we all agree with that sentiment. Really excellent. I want to just jump in to say previously I did include a link to a webinar that we hosted through the Tri-State Learning Collaborative on Aging. And in particular, this was a webinar focused on addressing the challenges of hoarding behavior. And the lead presenter was David O'Leary, who is the housing retention specialist for the Burlington Housing Authority, and he specializes in hoarding and squalor cases techniques and believes in a humanistic and compassionate foundation lies at the heart of his work. I was so very impressed with his presentation and the way they go about helping folks around hoarding issues. I don't know if he would have had any specific recommendations for engaging with someone with dementia, because he really wasn't addressing that issue. But since you have, I think, an emerging expert in your state specifically around hoarding issues, it would be great to reach out to him in future cases like that. Other recommendations?
Can you say his name again, please?
You bet. And I also did include the link in the chat, and we'll circulate it. His name is David O'Leary, and he serves as the co-coordinator of the Chittenden County Hoarding Task Force and is the housing retention specialist for the Burlington Housing Authority. Laura Gerard also presented from the Northern New England Geriatric Education Center at Dartmouth-Hitchcock, and also follows in their mechanisms in, their practices in New Hampshire.
Wow.
This is Laura Davey. Just kind of bringing the lens back out a little bit on the issue. I know one of the kind of the discussion questions is how agencies could coordinate potentially without permission. And I know that in New Hampshire, there's, communities have, service providers have wraparound conversations and create where they meet on a weekly or monthly basis. I'm sure this is common probably common across Northern New England. I think where my recommendation is to, while that is an opportunity to present cases and get feedback on. A lot of times they are like, oh, they can coordinate in a very HIPAA compliant way during those times. And I think also a recommendation is for all of our communities is to maybe, if that doesn't exist, create it. But if it does exist, we often have the same people sitting around the table, and maybe it's good to relook at who else we need to engage in these times with these really difficult situations, and town officials, right? To broaden the perspective and the coordination.
Very good.
I have a recommendation.
Yes, Cinda.
When you have difficult cases like this, and I've had lots of them over my 33-year career, I have found that the things that are most effective are persistence, determination, and when I don't know what to do, if I get stumped, I tell everybody what the issue is, and somebody always has either the solution or the next step that eventually leads me to a solution. And I think that Carlotta really epitomizes my recommendations. And I have found that persistence, determination, and just telling everybody you can think of is really been the most effective tool in dealing with these very, very difficult situations. And I'm so thrilled that I got to be a part of listening to this wonderful example of persistence, determination, and creativity from Carlotta.
Thank you, Cinda. Go ahead, Mark.
I absolutely agree with that. Persistence, navigating the bureaucracies of the guardianship programs and the various regulations that us service agencies live within. Persistence is key. I often recommend people like voting, they should contact APS early and often. That just keeping situations like this in front of people is critical. And the challenge in Vermont is that APS, well, actually it's not the challenge. I think one of the benefits in this situation is that APS punts self-neglect cases to the agencies on aging. And so I think the other recommendation is just continuing to use the networks like the community health teams, because honestly, having worked in Vermont for so many years in health agencies, I certainly respect the HIPAA regulations, but I have to say, honestly, I work around the edges. And so I'm often having conversations with people that around situations like this and trying to honor privacy, but at the same time, trying to work with people around what resources are out there and what information I can provide and networking. So I think those are all really critical pieces.
Thank you, Mark. Allegra, you have any thoughts? No? Okay. How about our friends from the Vermont or New Hampshire Alzheimer's Association, Melissa or Emily? Are you there? There she is. Can't hear you. Melissa, can't hear you. Annie, is she muted from your end?
She is not muted from our end, so I'm not sure.
Wait, can you hear me now?
There, yep.
Yep.
Okay, hold on. Sorry, I forgot that I had to call in separately for some reason. I will probably follow up later because I had to step out and I think I probably missed a few pieces of important information. So I very much apologize. I don't know if I saw Emily on earlier.
She is.
Okay.
Sorry, can you hear me?
We can, Emily.
Okay, great.
Yeah, Emily.
Yeah. I've been listening to all of everybody else's recommendations, and I agree. I was thinking, I was looking particularly at the question of coordinating between agencies when there's just a really complex case. And at that point, I would wonder at the primary care level if there's been any sort of release. I was trying to think back to my old days of working at a health center and where I would do a deep dive into somebody's chart to see, was there a chart or was there a release signed at any point when they became a patient here? Did they sign like a blanket release? So I know that it might be rare, but you may find those individual circumstances where there's at least just one agency that you're able to communicate with. And it can be really challenging when it's complex and there's so many pieces and moving parts. But my first initial thought would be that that'd be where I would start, is to see what may have been tried before, or if years past there was some sort of release signed.
And Molly Dugan, you want to jump in with your comment and thoughts on that?
Sure. I just know, anytime HIPAA gets brought up, there's so many different interpretations out there. And, I feel like every lawyer I've ever talked to about HIPAA has a different take on it. So I really try to reference, the law as much as I can, just looking at the language. And I know, there are these 3 exemptions to HIPAA for, healthcare folks. And I know that care coordination activities is embedded in one of those exemptions. Now, I'm not a lawyer, so I'm sure that maybe there's, some that would say that's maybe not their interpretation. But, as Mark said, I think there are situations like this where sometimes you have to make a professional judgment and document what your reasoning was.
And I would offer, I know that with difficult cases that I've worked on as an advocate, following up on APS cases, if we do team, for me, what it does is, instead of always wondering what's going on with this person or that service, it really holds us accountable, like who's going to do what next, and a timeline, so that we have an idea of what's agreed upon and an idea of what's happening. So that's I was going to say earlier, teaming and working as a group in a difficult situation, that's really been powerful for my work. So thank you.
Excellent, thank you. So our time has come again to an end. Unless there's any very short other recommendations that folks feel like they need to offer, I'm just going to call on Krista, who has been taking our notes today, to summarize the recommendations. And by the way, she's also the teacher and principal for her little boy, so, bear with her.
Can you hear me?
Yes. Yes.
Great, thank you. Okay, so the recommendations for today were getting medical providers who knew her prior, that she didn't have the capacity. It's important to do this early on. To have a physician make a house call, although not in the current circumstances. Important to have support for the caregiver helping the individual through cases like this. Getting a PCP involved via telehealth or a home visit. Have an advocate in your life, like a Carlotta, working step by step and trust. The webinar on hoarding that is from the Tri-State, reaching out to David O'Leary. Let's see, how the agencies can coordinate without permission, having weekly conversations and check-ins with cases like this, coordinating in a HIPAA compliant way, engaging new people in conversations such as town officials to broaden the scope. Tell everybody what the issue is. Persistence and determination, creative thinking is very helpful. Contact APS early and often. Continue to use networks like community health teams for networking. On a primary care level, look back in histories for anything that you could find releases signed. Use your professional judgment and document your reasoning.
That was great, Krista. Jess just emailed me and she has lost power, unfortunately. So I don't know if that's due to, but that was a great summary. I do want to remind you of our session next month. Will be the didactic will be the importance of legal planning and legal services for the elderly. And our case presentation will be Gibson Center for Senior Services. Mary Ann Jackson is the convener for that. We look forward to seeing you all again on April 23rd, hopefully not under the same circumstances of all being social distancing. But happy social distancing to you all and have a great afternoon. If the faculty could stay on, that would be wonderful. Thank you.